Hello and welcome to this webcast further in our series looking at how we can get efficiencies and deliver better healthcare, usually with less. Today's topic, a fascinating one, is understanding your practice variation and why that matters. And I have a fantastic panel as always to help us discuss this thorny topic. I'm delighted to introduce those in a moment. But first, I need to say, if you are watching this live, and some of you will be, please join in. This webcast is about you as much as anything else. In the comment section, you can put comments and questions, and we'll see if our panel can answer them. Please do involve yourself in the conversation. And what a great conversation we're going to have today, because firstly, I am joined by Dr. Kieran Madyan, and I'm going to ask Kieran, please introduce yourself, and whilst doing so, can you really just get straight to the heart of the question? How does a practice first recognize that inconsistent signposting affects efficiency? Kieran, over to you.
Thanks, Darren. So I'm a jobbing GP, a partner at Holbrook's Health Team, the practice in Coventry. Besides that, I'm also a practice director at Coventry Rugby GP Alliance and a federation director, board member for integrated primary care. Been a GP since 2008, and the first question strikes the heart of service provision at any practice, let alone in Coventry. How does a practice recognize? I think it's very consistent in how we look at things, especially when the phones start ringing first thing in the morning, when you find that the appointments are all taken up within a few minutes or perhaps in the first hour, and then you realize as the day goes that your staff, your clinicians come back to you to say, maybe this patient shouldn't have been booked with me, or the nurse says, this dressing patient shouldn't have been booked with me. And I think that's where, the practices will look at these inconsistencies, but the recognition comes from all staff, not the ones who are actually booking, but the ones who are actually delivering these as clinicians. So it's across the whole spectrum of clinical and non-clinical roles who will keep coming to you with the same bugbear to say, this patient shouldn't have really been seen today or shouldn't have seen me.
Look, that's really useful, and yes, I'm sure everybody can recognise that 8 o'clock rush. And Kieran, I've actually visited your site back in the day, when PCTs were around. I was actually vice chairman of NHS Coventry and Warwickshire, so I visited your site and seen the scale of that. Simon, talking about scale, I'm going to ask you again to introduce yourself, but if you could also answer the same question, how does that practice first recognize that inconsistent signposting and how it affects efficiency? Because I think in your introduction, you're going to explain how many practices you've worked with and the scale of this.
Yeah, hi, Darren. My name's Simon Bricknell. I'm the Healthcare Director for Developed Consulting. Non-clinical background, so my background comes from Toyota motor manufacturing, so that's where my sort of improvement expertise comes from. But I've been in healthcare for the last 20 years. And I've been part of the development of national programs that include the Productive Series, so one that started in the ward and moved towards general practice. I've also been part of lots of other programs across the health and care systems, but in the last sort of 13 years, predominantly I've been involved with improving general practice. And as we're one of the 5 national delivery partners for the current general practice improvement program that's run by NHS England, including the practice level support, we've worked with circa 2,500 practices. So we get some real insight into the day-to-day challenges that practices and practice staff face. On the question of variation, and similar to what Kieran's just said, I think most practices will know anecdotally that there's variation around how patients are signposted to different healthcare professionals. So quite often, I think GPs and clinicians will say to different practice staff in different meetings, why am I seeing this patient when this patient may have been seen by somebody else? But also, I think they'll get it from the patients as well. So I think patients will be coming back as a result of they've been signposted to something that probably wasn't appropriate in the first time. So I think anecdotally, practices will understand that there's variation. The key challenge is how do they quantify how much variation, and more importantly, what can be done about it.
Thanks for that, Simon. Can you give me, Simon, I'm going to stick with you for a moment. Can you give us is there an example of are we in a Pareto world where there's a real particular issue that there's variation over, that you see time and time again in every practice that we look at? Is there a particular one issue that just comes up time and time again, and we just go, if we could just sort that would be a huge part of the problem?
It's a really good question. I'm not sure. It definitely would form part of a Pareto, but I'm not at the moment sure about what that single one biggest thing might be. But I mean, we're going to come on to this in a bit about how you can start to identify it. But quite often there's a number of reasons about why signposting, certainly from the first contact, from having that interaction with a patient about who they might see, there's quite often a reason why they will send them to people that may be perceived as being inappropriate. And that might be down to lack of confidence. It might be down to a little bit about patients, I wouldn't say pressure, but patients want to see who they feel are the most appropriate. So I think quite often from a signposting perspective, it might be down to the fact that it's a lack of confidence, or the patient's asking for something and the signposter just gives what the patient wants because the patient feels that's the right need. But quite often it's not necessarily the best person that the patient might see. And
Kieran, in your practice, you've really analysed and looked at your variation. Do you see it's a practice-wide issue? Is there a particular difference between clinical and non-clinical staff and that signposting and that patient direction, particularly when the patient's leading?
I think there's a number of reasons why there can be a variation in signposting. It's not so much as a practice-wide, but I would look at it as more like internal and external factors. So there are things within the practice that vary. So things like staff attrition, where you've got a new member of staff who's joined the team. They are still waiting to be trained. They're in their probationary periods. They're going through some training. And then you take them through all the different signpostings, all the different services that are available to be signposted for. And at the same time, externally, things keep changing. So there are certain services for certain diagnostics or for minor injuries unit or walk-in centers. And there are certain times. So, some are open Monday to Friday, some are open 24/7, some are only open on bank holidays. So there's a lot of variation. But yes, looking back into things that we could do within the practice, I think it's mainly to do with how the staff respond to that training and the speed at which they can be trained for signposting, but also recognizing the fact that the staff will keep changing and this training will have to be a recurrent feature and not as a one-off.
And in your practice particular, how did the staff take to this measuring of the variation to start with and then implementing the change?
Oh, implementing the change. Funny story, that takes me a couple of years back when we did this. When we looked at implementing, everybody was trained in signposting. Everybody knew the different services. For example, the midwife, the local pharmacy, the first contact physio, the clinician, the nurse, the social prescriber, the mental health workers. But everybody was worried to start doing it. So nobody could figure out how to start it on day one. And that's where what I had to do was literally come in on the day, in the morning, an hour before the premise, the shop was open, printed out laminated posters to stick all on the wall on the front, where the phone's reception is and the phone's desk is. And when reception staff started walking in, I started showing them, look, this is your training. These are all the different services available for signposting. And today is the day we are going to implement it all. So as they kept reading through all of them, the one question that they all had in mind was, oh, but where's the A4 laminate which says GP? You've got laminate posters for midwife, social prescriber, mental health worker. Where's the poster for GP? And I kept pointing it at the very corner of the room to say, look, that's the last resource that you need to be using, because that's the most expensive resource, because that's the appointments that get filled in very quickly, and that's where the most inappropriate appointments happen. So you need to be reminding yourselves of the other provisions rather than going to the GP. And it was literally, product placement like supermarkets do. They'll place the expensive or the costly brand items at eye level, or perhaps the chocolates and confectionaries where children are down on the aisle. But yeah, that's how it was done.
Wow. And the staff literally on that day one took to it.
They took to it. It was a brilliant outcome because my physician associate comes to me 45 minutes later saying, Kiran, now the phone line's not working. What's happened? And the reason was because his appointments were not full up. He was like, well, the appointments are still there. Are the phones working? Are patients ringing in? And that's when I had to explain to them. And then the next thing is a GP walks in, and I had to show them the whole board in front of the phone's reception room, where every signposting, specialty was there. And that's when they realized that appointments were actually being used, better than how they were being just a day before. But it was that date of implementation where people were getting stuck.
And yeah, sometimes you just got to get on with it. Simon, you've seen this in literally thousands of practices. I'm not sure you've seen such a we're going to start and here's how we're doing it from 8 a.m. one particular day, or whether it's a more steady approach at other practices. I'm sure it's horses for courses. But have you seen different ways of implementing that, different ways of starting? And I'm really interested as well. How does a practice first understand its variation? Because until you measure something or understand that there's a problem, and you can't really fix it, can you, Simon?
Yeah, that's a really good point. I think we mentioned right at the start, didn't we, that most practices anecdotally will know that they've got this variation. But you're absolutely right, Darren. How do you then find out not only where the variation is, how big the variation is, and more importantly, what's the effect of that variation? And we know that a study recently suggested that circa 20% of GP appointments could have been seen by somebody other than a GP. So we know nationally that there's this avoidable appointment scenario. So some of that then can be contributed to variation in signposting. What we're fortunate enough to have when we go into the practices, certainly within NHS England, but this tool's now available certainly across the home nations, and that is we're able to look at not only what inappropriateness, each practice has from a week's study, and I know Dr. Kiran has done this in their practice to give them that percentage avoidable, but the tool also allows to do a 30-patient simulation. So this simulation means that every person in the practice can assess each of these patient scenarios and where do they feel is the most appropriate person to signpost in. It's a simulated exercise that people do individually across 30 patients. And there are about 6 areas for the patients to be signposted to. When each individual has done that, and that's the non-clinical team, the signposting team, and the clinical team, then you can start to understand where the variation is across individuals that have done that simulation. So where did I as an individual put each of those 30 patients? But also you can see the variation against where each of those patients, those 30 patients went. And that's when it starts to get really interesting, because then the practice with the analytics that come as part of the tool can start to have conversations about how they can improve and reduce that variation. The interesting point here is that when you've got clinical variation, that tends to be the box that's quite hard to discuss, because, and this is not about telling clinicians what's right or wrong, this is identifying that there's variation and getting the clinicians to come together to have a conversation about why that variation exists and what they choose to do about it. The other point I'll just mention while we're talking about this ability to understand the size of the problem using the simulation, Darren, is that the simulation also asks, what do you think the urgency of seeing that patient is? And that's an interesting point where you've got variation. So again, a signposter might say, oh, I think I'll get over to you can come back in a week to see the GP, etc. Or somebody might say, well, actually, I think the GP needs to see what you're presenting with today. So again, the simulation is a great way to be able to show not only that you've got variation because it's anecdotal in your practice, but actually, how do we show it individually, both non-clinical and clinical?
That's fascinating stuff, Simon. And I'm going to come to Kieran in a moment, because I'd really be interested to see from a practice perspective how going through that simulation felt and worked. But Simon, at what scale, how many people have ever done this?
Yeah, well, currently I think there's around 15,000 individuals, clinical and non-clinical, across NHS England that have done the simulation. So, that's a fairly substantial number. And I think practice-wise, I think that covers around about 1,200 practices that have currently done the simulation.
Wow, so this has been rolled out at scale and has been proven to work. And obviously, if so many people are taking it up, there's something pretty good about it. Kieran, tell me about your experience with that simulation. And by the way, just a bit of signposting. There is a QR code at the top of the screen. If you scan that, I'm sure it will take you to the appropriate appointments product if you want to understand a bit more about it. But Kieran, tell me about your experience.
Thanks. So Darren, what we did at Holbrooks was that with the simulation, we got the staff to go through the 30 case scenarios. And yes, like Simon says, that there was a bit of variation between the clinical and the non-clinical staff. But I think part of that was because of how risk averse or what the risk appetite was for within the staffing team. And you will notice a palpable difference of risk appetite with the clinicians as compared to the non-clinicians. But I think here, if we focus mainly on the non-clinicians or the reception staff or the admin who are actually on the front line and who benefited the most from this tool, was when the analytics came in, we then went on and did a sort of skills matrix on each and every available signposting option. So say, for example, midwife, on a skills matrix Excel sheet, how confident was staff A on a level of 1 to 4 to refer somebody for a midwife, or say, for example, a physio, or the eye casualty, or the local pharmacy, or to a GP or a physician associate or a nurse. So we developed a skills matrix from the analytics, and that was fantastic because on the matrix, the 4 levels were from, have absolutely no clue how to do it, to somebody on level 4 who could actually become a trainer for somebody who was at level 1 and 2. So with the simulation tool and the analytics that followed, that then helped us to identify the staff, because not everybody needed training in everything. And that's usually always the case. It's like when you paint home, not all your walls will need an undercoat every single time you go on to redecorate. And this is where some of the experienced staff took on that additional responsibility of being a trainer to teach others on the various signposting options that were available. And then every 3 months, we visited the skills matrix again. It's been 2 years now. And we take opportunities during the PLTs, the protected learning time, to rerun the simulation and keep updating the skills matrix. Also, when staff attrition and when new staff join, we embark them on the same program. It's a wonderful training tool.
And so you've got that skills matrix. Do you also revisit the appropriate appointments simulation? Do you redo that?
Yeah. So like I said, every quarter we do that. It's almost like a deck of cards. So You have to remember, it may be online these days, but when we had it as a deck of cards options, and then next year got to do it online. So we've actually done this twice. So we've still got the original deck of cards with us with the 30 simulations. So we just set it out, and play that every quarter. And it's fascinating to see that.
I'm sure there's an element of it being a little time consuming, but what sort of do the staff enjoy doing it? Do they come to this with alacrity?
It was they were very skeptical and worried about it. One of the staff was also questioning, are you trying to performance manage us? No, this is not about you. You have to remember, this is the NHS. We are not in the business of selling cupcakes and potatoes, and nothing wrong in doing that, by the way. But this is a patient service. This is NHS. This is free at point of service, at point of provision. So the patients will want to always see a GP, but it's how well trained our admin and staff are to actually appropriately signposting them to the right person. Because a GP won't know how to do a dressing. A GP won't necessarily know how to give advice on physiotherapy for back pain. And a GP won't necessarily be qualified, well, not all are, to fit an implant. So if you're not doing an appropriate signposting with the very first contact, it increases the inefficiency and reduces the satisfaction. So staff were cautious, but they loved it, they enjoyed it, and now they actually look forward to doing that because it acts as a refresher.
That's really cool. Simon, you've clearly seen this done at multiple practices. How do you see staff take it? Do you see that they enjoy it? They're asking to do it again, and is quarterly about right, or should people do it half yearly, quarterly? What do you think?
Yeah, it's really great to hear Kieran reference the cards. So just for clarity, before we had the online tool, the appropriate appointments online tool. So Kieran's absolutely right. We used to have 30 patient scenarios as actual physical cards, and then the team would have to put them into the different areas that they felt they needed to go to. And then you'd have to do some very manual analytics on the back of that. And even in that format, I think all the staff members seem to enjoy it. That would have taken a little bit longer, but it was still enjoyable and still useful. But very quickly, we realized that actually there must be a better way to do that. And the fact that we've now taken that simulation online, it's very interactive. So you can do it at your own pace. It would take probably average about 15 minutes to do the 30 patient scenarios. Any access to a computer screen, phone, you can do that outside of work. So actually the ability to individually do the simulation is not only quite enjoyable, but you can do it within your own time. Once all of your staff that you've identified that you want to do it have done the simulation, then the analytics of all of the different scenarios, where each patient has gone, where each individual has signposted them to, and remember that urgency question as well, is available real time. And then that's when it then really starts to become interesting. And I just want to pick up on a point that Kieran also mentioned there. And there is almost this skepticism about doing this around performance management. We never use that term performance management or measurement for judgment. We use that as measurement for improvement. So understanding where the variation is not to say somebody's doing something wrong. It's understanding that it's there and how can we improve it for whatever the outcomes might be. So I think, yeah, in answer to your question, Darren, it's really easy to do. I think every individual that does it quite enjoys doing it. And then more importantly, they can't wait to see the analysis, not only to see where they fit in the whole scenario of the variation, but also what are the results telling them, and what, more importantly, is the potential then to improve processes, inefficiencies, and then the benefits that those improvements bring. And some of those will not only be to the easier working life for the staff, but more importantly, or as importantly, it can help patient access, patient outcomes, seeing the right person quicker at the right time, etc. So yeah, it's a great way not only to understand the variation and where it might go, but the ability doing the actual simulation is quite fun as well.
And does the tool really help understand what not even good looks like, but what great good looks like? Because you can have variation where one person's doing something that's good, but somebody else is doing something that's really good. And does it help identify what great looks like?
Yeah, absolutely. And obviously there'll be certain scenarios where, as Kieran's referred to, they'll put training and best practice sort of things. But the thing that we quite often see is that you'll have, I won't refer to them as champions, but you'll have, or even experts, but you'll have one individual that stands out. And you can see that actually they're always quite on it, and their variation is quite small. So quite often the different individuals can learn from that individual about what it is, and it can come back down to confidence, that risk sort of scenario that Kieran mentioned before, building that confidence, but learning from somebody who's got what good looks like is a really useful way and a fairly safe way for people to learn rather than feeling under pressure. So I think that peer-to-peer sort of support around somebody, and that could be down to experience, but the analytics will show that there are potentially individuals that are, like you say, almost the best at signposting.
Thanks for that, Simon. I'm delighted to say that Mark Brown has put a comment in there. Again, if you're watching this live, please do comment and put your questions forward. So I'm going to put Mark's question to you, Kieran. The analysis sounds useful, but what do the practices do with this information? I know you've given us one anecdote, but what else have you done with that information, Kieran?
Thanks. So Darren and Mark, the information that we get from this, its use is not only towards the patient, where the patient then gets to see the right person for the very first time or at the first point of contact, because that information can then be used by us to train our admin and reception team on how to do the signposting. Like I said, with the analytics, if you have a skills matrix of all different options available to you that you can signpost to, get all the staff to show their level of confidence in actually signposting them. So find out from the staff on how confident they feel to refer somebody to a physio, or why would they not refer this to a GP but to a midwife. And then you could go on to train the staff. So if you train the staff to the right signposting service, then the patient satisfaction increases. You will have less staff turnover, so your attrition rates and your retention rates will be better. So you will have a dual advantage of not only serving your population better, but also within the team, there is a greater level of confidence and satisfaction. And above all, your clinicians will be thankful to you for having trained the non-clinical team, because you will get less of, you'll get less comments of, why did so and so refer this patient to me, or why couldn't this person have seen this patient. So it's that variation that you can get rid of, but you can't get rid of it till you have the information. And once you have the information, you can then use the skills matrix to analyze that to nobody's detriment and to everybody's advantage.
So Kieran, you've got this tool that's removing blame culture, and it's a learning culture and whatever. And there's a lot of, you can look internally at what's our confidence level about referring to this service, that service. Have you involved those other services, those externals, the midwives or the pharmacies, to talk to your team, to give that additional confidence so that you can move from a 3 to a 4?
Yeah, so we take the opportunity during the PLTs or the protected learning time in the afternoons where the practice is closed. So clinicians are attending a PLT program, which is managed internally across Coventry. But then at the same time, the admin team gets to speak with different, the specialties such as midwives, social prescribers, link workers, pharmacists. And that's when they come in to actually educate the staff on what service provisions or what's their spectrum of offerings. We also use clinical meetings and reception meetings to make people aware within the team of any service changes. So, there might be a service that might be there today, but not there next year. So we take every opportunity, which is perhaps at least once a month, to train the staff on the different service offerings. And we do involve, midwives and the support services, like we call it, to come in, invite them in, and talk about their offerings.
And how happy are they with this?
Oh, they love it. They feel valued, because it's often seen as, oh, it's only your general practice or the hospital, but there's a whole world out there that supports both primary and secondary care, and it's this out of hospital care provision, which is the community that helps support general practice. They see it as a win-win, because it increases their level of offerings, the number of caseloads that they've got, it increases. And Darren, as well as I do, that all contracts on the NHS are either on a year or a 3-year basis, and that actually helps these services continue to bid for the contracts on an ongoing basis.
Thanks. So, Simon, as we see in England, but we're now seeing in NHS Scotland, NHS Wales, this move more towards that neighbourhood teams and community teams. How do you see this as part of that and that involving all the services around the GP practice and that front door really working?
Yeah, I think obviously there's the move more towards neighbourhood working and using resources at scale, obviously. I think the interesting point about where this tool comes in from that scenario is that not only can you see the practice variation within a practice, and that's what we've been talking about, but if all of those practices that are considering working closer together as part of a neighbourhood also have this information, not only are they able then to use the analysis to think about resources and signposting and how they can improve some of those things on the back of it, but I think it also gets them much closer to being able to work at scale with some of the information that they've got to better outcome for the patient. And again, all of the things around improving access, when they're starting to look at the lens through an access model at scale, again, I think that this information can help. And not only that, we're setting up neighbourhood teams, but who do we signpost the neighbourhood teams? Who do we signpost to things that are hubs that are being generated as part of this new neighbourhood working? So the information within this scenario can help in different aspects. And yes, neighbourhood working from the analytics at scale is great, but if you're setting up hubs in certain areas, the risk is then that they're getting signposted inefficiently or inappropriate to those hubs and the individuals that work within those hubs. So I think, again, from a neighbourhood working potential, then understanding the variation around signposting could be really useful.
So we've looked at it really very much through the eyes of staff here and how it makes life easier for them. Let's talk about the patient. Kieran, how do patients feel when they're not signposted to a GP? Does it take time to build that confidence with them?
I think it's how you put it across to them, isn't it? So it's the case of explaining what an alternative appointment would actually mean for the patient. So take, for example, a steroid injection, which the staff might very well know that a certain GP isn't qualified to do, but they do know that there is a first contact physio in the practice whom this patient could very well see and get the steroid injection the same day. And I think it's how you sell it to the patient, where the patient then is a bit more amenable to that appointment. And once the patient has seen the first contact physio, had the steroid injection, that's when the patient realizes that this is actually beneficial for them. So I think patients are a bit skeptical because they would always want to see the GP. It's the same with outpatient appointments. When you go to an outpatient clinic, you waited 12-18 months for an appointment to come through. The only person you want to speak with is the consultant. But the consultant has a team of registrars, a team of nurses, a team of junior doctors to support them. The same is the case with general practice. It's not so much that it's a GP service, but it's a GP-led service. So we work alongside a team of various individuals who are both within our practice and outside our practice. And it's this signposting that patients are becoming a bit more receptive to, provided there is the correct awareness. And that can be created through the practice websites, through the welcoming message on the telephones, or through signposts all around your surgery. So there's a lot of way you can increase that awareness and make patients take the alternative signposted appointment.
Simon, you must have seen plenty of cases of this. Somebody rings up, I want to see a GP, and when they're told, no, you should go in, I'm going to put you an appointment with, I don't know, a physio, whatever it is. How have you seen different teams trained or directed to really engage with the patient and explain this is why you're going there and this is why it's going to help?
Yeah, yes, there's this scenario there about what's right for the patient and then what the patient feels is right for them, sort of thing. So, and we've seen lots of different methods. Kieran's mentioned a few there. We've had when a patient first rings up, if a patient's put on hold, there may be a voice note from the lead GP that's explaining to them that you may be positioned away from a GP because that's the most appropriate person to be seen. So that there's maybe a technique there where some practices have used a voice note while you're on hold, the patient's on hold, and this is the lead GP introducing himself, and just to let you know that our signposters are trained in these things, and even though you may feel you need to see a GP and that may be the result, you might be signposted elsewhere, but if you are, it will be for the most appropriate professional for the condition or for the presentation that you're presenting with. So I think that's one example that I see quite often where people put this voice sort of note at the front of their telephone system.
Oh, that's good. And Simon, you've sort of you will have seen it across lots of practices. Is there anything that a real difference between the signposting from a clinician and a non-clinician? Is there an issue there that people don't want to be signposted to something from someone that's not clinical?
Yes. Well, I mean, the first thing, one of the good things about the tool is this differentiator between a signposter that's non-clinical and how a clinician would have signposted. So that's an interesting scenario. So thinking about the clinical side there. And again, once the clinicians have got that analytics and they see that there is variation across their clinical team, the main thing that they need to do then is come together and discuss that. Because quite often there'll be variation for a number of different reasons. And there's sort of two easy ways to think about what that is. The first one, is it acceptable variation? So quite often when we show this information from a clinical perspective, they will say, well, we think that's acceptable variation. The fact that actually this patient could have seen this person or could have seen that one, they're both sort of okay. But unacceptable variation is where they've said that a patient should have seen somebody and another clinician said they should have seen somebody different, but they agree there shouldn't be variation there. That should absolutely be seen by this professional. And there they might be few and far between, but the identification of those, again, fits into that hard box. And quite often that hard box is never discussed because you don't understand the clinical variation that's within the practice. To be able to then to have a discussion across your peers about what is acceptable and what isn't around variation is a massive step in the right direction from understanding something that we absolutely don't necessarily know within practice when we're talking about clinical variation.
Just on the comments there, Sarah has put a comment, Sarah Jones, and I'm going to put this to you, Kieran. Do you feel that giving the patients more of that information actually empowers them, and by giving them options for their care, as an example, that really makes them feel that they're in control?
Absolutely, Darren, yes. And Sarah, to go back to the same example that I was discussing earlier about the patient being offered a joint injection by first contact physio, had that patient seen a GP who wasn't qualified to do the injection, the GP would have still made another follow-up appointment with the physio for the steroid injection, which means, yes, the care is appropriate, but it's not timely. And that takes the patient further away from them going back to a normal life, perhaps pain-free, going back to a forklift driver or whatever they do. But also, if you look at other examples, for example, the asthma nurse has a 20-minute appointment for annual reviews with asthma patients, but the GPs generally have 10 or 15 minutes for appointments and consultations. So if my team were to book an asthma review appointment with a GP, then I don't think there's justice that's done. But if the patient is made aware that, look, if you see an asthma nurse, it's actually a 20-minute appointment, they will take you through your inhaler technique besides doing everything else, then I think the patient feels much more in control of that appointment, and they feel empowered. So they will actually turn around and say, you know what, I do want to see the nurse because she did explain the technique to me better than the GP. Well, better probably because the GP doesn't have the same level of time commitment. And I think that's where, if you give patients that choice, they do generally make a sensible choice from that. So I hope that answers, Sarah.
No, that's great, Kieran. And Kieran, staying with you, at your practice, you've used the appropriate appointments tool. You've changed how you signpost. You've changed how people feel about signposting, and you've trained people up. What is the actual outcome? Have you got any data on this has freed up X number of GP appointments, or we've referred more people to physio than we would have before, or people are getting more timely treatment? Have you got any data?
Looking at our data within the practice, at least 2 out of 10 appointments that would have previously been wasted have now been better utilized. In fact, when we first did the actual collection for avoidable appointments, I've got the data report in front of me. 39% of face-to-face appointments were deemed avoidable by the clinicians who interacted with those patients in that 1 week of data collection. So the numbers won't always remain that high, but even today, even till date, it's about 15 to 20% of appointments that we utilize much better had we, not, had, with the help of the tool. But if we didn't have the tool and the training that has followed, then I think we would have lost at least 2 out of 10 appointments every single time.
That's an astonishing figure, 20%. That's a big number. And do you have a feedback loop with the other services, midwives, whatever, that they will tell you, actually, you referred that and you shouldn't have? Is there a safety net there or a feedback loop so we continue to learn?
So some of these services, there is a feedback loop, but the others, there isn't. So for example, the community pharmacy referrals, there is a feedback mechanism where you get the outcome on the same day. From the eye casualty, there is. From A&E, there is. From minor injuries units, there is. But then some of the others are a bit more softer approach to feedback. So, things like, especially with safeguarding or with social prescribing or with mental health teams, they will not reject the referral, but they do provide some, signs within the outcome letters to say, perhaps you could have done this alongside doing this as well. So not all signposting is correct all the time, but it's more to do with certain specialties where we can quickly adapt ourselves. But then the other specialties, especially mental health, safeguarding, and child protection, where it comes down to the risk appetite, where the clinicians would be much better and accurate than the non-clinicians, and absolutely, there's no finger pointing to anybody for that.
Right. And Simon, up and down the UK, you've seen this being implemented. How much of this is down to the practice, and how much is the wider health economy, and how much of this is down to health boards getting involved or ICBs in England, and how much is on the practice? Because this has all sounded very practice based, but have they got an influence on this?
I think they absolutely have. Obviously, I think there's pressure in general practice at the moment. There's pressure to be able to provide appointments. Obviously, there's pressure to be able to improve access for patients. All these different pressures, and I think we're just talking here about an example of practice level, how they can do something about that. But yes, if you're thinking about wider health boards, etc., to be able to have some of this information again at scale will open those conversations to be thinking about how things can be improved on a much larger scale. And don't get me wrong, we often refer to something as failure demand. I'm just going to bring this in at the moment as well. So failure demand is something that happens as a result of something not being right first time. So whether that's a patient interaction being signposted somewhere inappropriately. Quite often we see that a practice, from a failure demand perspective, a practice tends to about 10% of failure demand, something not happening right first time, is as a result of the practice. But quite often we see a similar percentage as a result of the wider system. So that we know that there's issues around failure demand, things not happening right first time, both from a practice perspective within a practice's control and in a system perspective outside of the practice's control. Using information like this at the health board level or something at scale can help improve both of those scenarios. How can we use this information to improve in the practice, but how can we incorporate that information to know that there's also an issue from a system perspective, identify what that is and the variation that sits within it, and then improve on a scale rather than just at a practice level. And that's where I think it gets a little bit more exciting about the potential benefit to a balanced scorecard of patient outcomes, patient access, patient satisfaction, staff well-being and working lives, and practice efficiency. And then ultimately, I would suggest cost as well, but I won't go there.
So if we've got several practices in a region doing this, we can actually see that there's variation, not just within the practice, but one practice will signpost that way and another practice will signpost that way. And
Absolutely.
We can rebalance the system.
Yes, absolutely.
And I'm not sure if you've got the data on this, but have you seen this with your own eyes, that there's a real difference between two practices that are on the same patch?
I have, and we're in the process at the moment. We're just in the process at the moment of going through those 15,000 individuals and those 1,200 practices to be able to create some kind of overall dashboard to show the variation at practice level, in the NHS England at PCN level, but the same could be done at different health board level, etc. So we're hoping to have that study and those analytics probably available in the next few weeks. So that'll be something interesting to look forward to. I've started to see what that is, and it's interesting. So bear with us on that one, Darren.
And I assume once you've got that data, you can. I know you mentioned cost and said you weren't going to go there, but there's a potential here to really understand a large cost saving, and also then giving better access across the patch where it all starts working together. Kieran, we've just talked about system variation. I know you touched on this earlier, but Mark Brown in the comments has put given us another question, which is great. He's just saying, do you see significant variation in that clinical team when you first started this?
Yeah, I think it's the question is, when it says significant variation, I would tweak it to respond to say, is the variation acceptable? So is there an acceptable variation? And I'm speaking as a GP trainer, the way we look at variation within the clinicians is to see if that highlights a training need within a clinician. So I'll give you an example of puns and dens where patients' unmet needs are doctors' educational needs. So, if there is a significant variation, if I've got 3 physician associates or 3 GPs who are all giving varying answers to the same simulation where, you feel that this patient should have been dealt with by them, you would then find out as to what the actual reason is. And sometimes, well, not sometimes, usually the reason is clinical. So either they are not confident, or they've never dealt with that situation before, or the most recent time that they've actually dealt with a similar case before, it has ended up in a patient complaint against them. So I think that significant variation can be useful. There was one that I can think of where one clinician was not very comfortable seeing a certain set of patients. It was very clear that there was a training issue, but this simulation will bring out those differences. It's what the practice then does with it. And I would say, don't look at it as whether it is significant or insignificant, but look at whether that is acceptable or unacceptable, and approach if it is unacceptable, because no 5 fingers will be alike. So, a GP in their first year of training or in the first year post-qualification will not see the same spectrum of patients that, somebody is seeing with years of experience. So, yeah.
So how have you so you've got the clinical variation there, Simon? What if a practice is basically hasn't got a variation on something, but the signposting's wrong? Does that come out with the simulation? So they're all signposting this way. Everybody is for a particular issue, but it's not necessarily the right one. Is that where the system needs to have a view on it?
Potentially. I think, firstly, I'm yet to see a practice with no variation. That's the first thing. And when you've got 30 patient scenarios and, 2 people, I can guarantee that you're going to have variation. So that's the first thing. I think agreeing what the level of variation of what the right answer is again interesting, because there will be certain patient scenarios where there'll be some of that acceptable variation that Kieran's talking about. I think where the system can be supportive is to be able to understand, again, based on patient need and appropriateness, about some of the things that might need to change to make sure, because the ultimate goal that we're trying to aim for here is that the patient sees the right person, the right professional at the right time. And that's really important. And that goes back to where we were earlier talking about this variation around urgency as well. And that urgency can be felt by the patient as well as a signposter. I might feel that I need to be seen today, but actually my condition doesn't necessarily need me to be seen today. So I think the practice can start to understand lots of that variation, because there will never be zero variation, and what can be done with it. And I think the system having that information that we're about to produce, I think will be really interesting to understand how they can improve elements of the system to make sure that patients see that right person at the right time in the right place, and that access model is improved drastically.
Kieran, I don't know, does your practice have a patient participation group, and what's their feedback been?
Yeah, we do. So we restarted the PPG, the patient participant group, after the lockdown was released, and they do have a certain level of say on the services that we offer. For example, when we started signposting our patients to social prescribers, we had to increase the number of social prescribers that work at Holbrooks. So we started with 1 about 18-20 months ago. Now we've got 4. They don't work full time. They all work part time. But that was the level of demand. So purely due to signposting, patients absolutely loved to see a social prescriber who would be able to give them that time and the resolution of the problem, which wasn't necessarily clinical. And I think that's really helped. It also helps us to recruit. So, for example, my first contact physio, the second FCP who's joined Holbrooks, so she's now gone on a steroid injection course, which is why that example came to mind. And patients are delighted to be able to see a physio who can inject. So it's not as simple as playing darts on the knees, but a fully qualified physio, when they do it, patients love it. And the PPG, that's where they decide. When we ask them, do you need more GPs, or do you need more of a certain level of specialty? And that's really useful.
Simon, in Kieran's practice, you can sort of tell that Kieran's been a real leader, an advocate for doing appropriate appointments and then changing the signposting. Or who do you see takes the lead on this at practices? Does it tend to be clinicians, or is it practice managers? Who tends to run with it, or is it different all over the place?
Yeah, it's different all over the place. When any practice sort of embarks on any change, there can be a number of routes for the reason why they're doing that. It can be pressure, as in performance, as we've mentioned before. It can be an anecdotal that they know they need to improve because things are happening. So I think how they get into change is going to affect who's the best leader for it. But bringing it back to our topic around signposting variation, the appropriate appointments online tool is a really nice way to get into a practice, to start to understand things that are happening, so data to show how big the problem is, or the issue is, or the potential for improvement, And then how can they embark on, okay, let's now change things and identify where the benefit might sit. And brings me back to that balanced scorecard of patient, practice, staff, etc., etc. Who leads on this from an appropriate appointments perspective tends to be the practice manager, but that's more from an administration perspective. You need somebody to lead the team through using the module. But actually, when it gets to the actually implementing the changes, then that can be a multidisciplinary team. You know, you want some sponsorship from clinicians to help and support the staff to make the right decisions. You want voice of the admin and the signposting team because they've got they've got their part to play. So I think who drives this module tends to be the practice manager in this scenario. Who drives a change? I think then it becomes a collective of making sure you've got management, making sure you've got sponsorship, making sure you've got guidance, enthusiasm. And then for me, the most important thing is the so what question. So when we start to do the changes, what has been the impact? You know, how many appointments have we avoided? Whether you go down the cost route of that or you go down the effect route of that from a quality perspective, the point is we've now identified something using this tool. We've now identified some changes. Let's now measure the benefit of those things. And hopefully that starts to improve the lives of the patient, the staff, and the efficiencies within the practice.
Kieran, does that sound true to you? Who was the real sponsor in your practice? Who got this going?
Yeah, I think at Holbrooks, it was both the practice manager and a clinical. So, you know, as a clinician, I took the lead on this. The practice manager followed suit. Very early on, we did identify, talking about participation, you know, who should participate in the program through the actual process. You have to identify within your team individuals who are a bit resistant to change, and you need them to buy into this idea of signposting. So we did try to explain this and discuss this in the reception meeting, particularly with the couple of staff members whom we felt would take this as a performance management issue. But once we had their buy-in, it was absolutely rock and roll from there on. So I think one clinician, one non-clinician, it could be the manager or the deputy, but one clinician, you know, along with the manager, alongside any staff whom you feel will be resistant or fearful of learning something new, if they buy in, then, you know, you're all set for success.
Thanks for that, Kieran. Kieran, we've got 2 minutes left. In 30 seconds, what's your message to practices, to health boards, to ICBs around this issue of signposting?
There is much more variation than you currently think you are facing. And this is a fantastic tool. This is an opportunity that you can use to identify that and to deal with it, which is where you will change the perspective and make it a skills matrix training issue rather than a performance management. And that is where you will change the significant variation to an acceptable variation.
Thank you very much, Kieran. Thank you for your time. Simon, last word to you. As Develop Consulting and IOP have sponsored this, you get your 40-second sponsors pitch. Go on, tell us about it and how people can engage with you.
Yeah, well, we've mentioned about our experience and the amount of practices we work with. On the back of that, we've created a number of different products and service offers, of which Appropriate Appointments Online is one of them. It's a great way to get involved with change. It's a really easy way in. We've mentioned about how the tool works. It's very engaging. It's easy to do. There are two elements to the Appropriate Appointments Online. There's the simulation that we spoke about in depth and that 30-patient scenario, but there's also the ability to use the tool to understand how much avoidable or inappropriateness you've got within your practice. And guess what? You can use it like Kieran does as many times as you want throughout the year to be able to track how those improvements and that variation is reducing. And if you're interested, you can use the QR code that's on the screen. I think that will take you there straight through to the tool that we're talking about, or you can contact us through the DC website and we'd be happy to either have a conversation with you, send some more information, or even, why would we not give you a demonstration?
Hey, thank you for that, Simon. Thank you for your time. We are now out of time. I've been Darren Jones. I've been joined by Simon Bricknell and Dr. Kieran Madian. Thank you for your time. And please, if you've enjoyed this, please signpost some of your colleagues to have a watch of this and some of our other webinars. Thank you and goodbye.
Bye.